Good evening, Hiren. Good evening.
Sir, good evening.
We missed you today in our class.
Sir, I'm in Goa, sir. It's my
I
sister's
know.
birthday today.
I know. I know.
My sister ni birthday se aaj.
Yes. Good. Good.
There's 1 minute. I'll give it to her.
Happy birthday.
Yeah. Gaurang Shah, sir.
Hi.
Hello, how are you, sir?
I'm fine. All fine. Happy
Good
birthday
to
to
see
you.
you after a long time.
Yes. We'll meet sometime.
Yes, definitely, sir. Please do come home.
Yeah.
Thank you so much for your wishes. Thank you.
આને વાત કરવી તમારી સાથે.
Hi.
આવી ગયા તમે ઘરે?
હા, હું જસ્ટ ઘરે આવી ગયો. આપણે 5 મિનિટમાં પછી ચાલુ કરાવીએ.
યસ સર. હું જરા મ્યુટ ઉપર છું કારણ કે બહાર છું એટલે.
Yeah, no problem. Okay. Who is answering today? Anand, you are answering?
Yes, sir.
And Giriraj?
Yes, sir.
Okay.
Recording in progress.
Sir, you can start the program. Actually, sir, technical team not receiving my call to make host, but recording in progress, sir. As soon
Okay,
as
okay,
he joins, sir, he will
I'll
make
go
you
and sleep.
host, sir.
okay. And I think then uh, we should start then. I'm just
I'm
waiting
not
for Dr.
commenting,
Vijay.
but sleep. You do one thing. You turn on the AC. I'm coming. I'm just coming. I'll bring Bhaiya also there. Come on, let's move. Okay, let's put that.
Please unmute those who are answering.
Wood in
Good,
open. I'm going to turn on AC.
hello. Good evening, Gite sir. Can we start now? I think we should start.
Sir, good evening, sir.
Good evening. Because Pankaj told me that he has got a council meeting, so he will join little late.
ठीक है sir.
Hiren is there. He will be, answering or asking question in between.
Yes, sir.
Okay. So, sir, today Dr. Gite sir will lead you all exactly as per the exam. Okay.
Yes, sir.
Fine. So, who are answering? Just tell him.
Sir, myself, Dr. Giriraj from Puttaparthi, sir. Satya Sai.
Okay. And
Myself, Anand, sir, just of Mumbai.
कम कर दे मैंने.
Anand and Giriraj.
Yes, sir.
Okay.
तो मैं क्लास भी
Okay.
है. आप सो जाओ, मैं क्लास पर अटेंड कर रहा हूँ.
Okay. Fine. So, Brijesh, you can start.
Yes, sir. Good evening. A 29-year-old male present with a complaint of pain over left flank region since 2 months with burning micturition and increased frequency, and similarly pain in the right flank region since 1 month.
Okay. So, Giriraj, this is a history.
Yes, sir.
Okay. You just tell us what are the important questions you will ask and what is the probable diagnosis that is coming to your mind.
Sir, whether pain is intermittent or whether is pain is what is the nature of the pain?
हुआ? हाँ?
Sorry.
Giriraj, you can continue.
Yes, sir. Yes. So I like to ask, what's the nature of the nature of pain, whether it's a colicky pain or a dilating pain, and whether it's relating to the loin to groin, whether is any associated with any other whether yes, sir.
No, someone is talking in between. I don't know who is talking. And because we are not hosts, we cannot mute everyone.
So I like to ask any other history of any other associated history of fever, vomiting, any other any history of urological intervention in the past, and most probably with given history in a 29-year-old male, left flank pain since 2 months followed, and he's starting having lower urinary tract symptom with burning micturition with storage symptoms since 2 months, and pain since 1 month. So my first differential diagnosis I like to keep as a urolithiasis. The second one as a young male with bilateral flank pain. The next one I will like to keep PUJO, pelvic ureter junction obstruction. And the third one as a bilateral flank pain. First I will keep as a renal cystic disease, and the fourth one as a patient having lower urinary tract symptom in which is a more specific storage symptoms. So I'll like to keep tuberculosis in the last in my differential diagnosis.
Okay, fine. So Anand, this is a this thing, history. Can you just elaborate anything extra in the history, how you will go very systematically as far as the pain is concerned, and then the burning or the
Sir,
frequency?
I would like to elicit the pain motion, its onset, duration, and progression. If the pain is insidious or means insidious, or and the nature of pain, so whether it's colic or diluting, and is associated with aggravating or relieving factors and radiation of the pain. Uh, and depending on the nature of the pain, it is pain is in the left flank. Also, a patient is having frequency also. So such kind of presentation is most common in leaves effects. Specifically, stenosis fascicular leaves effects. Rest of the disease we have already discussed. And also, yes.
Okay, fine. Gita sir, your comments on all these things.
Sir, he told already important differential diagnosis like urolithiasis, PUJ, infected cyst, complex or simple. Then these are usually common diagnosis which can consider at this age, and priority wise urolithiasis is more common considering the age of the patient. Second is PUJ, third is cystic disease. And burning micturition increased frequency, that is another factor here. And the age, again, it can be a tuberculosis stricture or tuberculosis down the line. It can be pain भी हो सकता है और lower storage symptoms है तो tuberculosis भी रहने का चांस रूल आउट नहीं कर पाते. डाउन द लाइन अगर किसी रखना चाहता है कोई तो वो रख सकता है.
I think fine. So he has covered almost all the
Exactly.
history, the full history.
Yeah, he has covered majority of the differential diagnosis.
Yeah.
Who is talking in between? Who is talking in between? Please leave the hall. Either keep mute or leave the hall.
Yeah. Okay. Thank you. Fine. Okay, Bridges. Go ahead.
So he was relatively asymptomatic before 2 months and he developed a pain over left flank region. Pain was colicky, sudden in onset, radiating from loin to groin and gradually increased since 1 month. He also had burning micturition and associated with nausea and vomiting. There were no specific aggravating or relating factors. And patient also had mild pain over the right flank region, which was similar in nature. Both were relieved on taking analgesic. No any other storage or voiding lungs.
Go ahead.
He didn't have any fevers or chills, no history of leukorrhea in the past, no hematuria, no any catheterization or instrumentation, no any puffiness, breathlessness, no any lump, no jaundice, backache, bony pain, or no any bleeding disorder.
Complete.
There were no any significant past histories. He didn't have any allergies. Family history was also insignificant. His personal history was normal. Diet was mixed diet, and his bladder symptoms were altered because of burning micturition.
Fine. So, Gilraj, this is a history.
Yes, sir.
Now what you want to do?
Sir, as my differential diagnosis urolithiasis, so I would like to proceed as my initial routine blood investigation and then followed by initial imaging. So I might like first investigation, I like to order as a routine blood test, complete CBC and urine routine, serum creatinine, uh, and serum electrolyte. Followed by I would like to do one X-ray KUB and ultrasound first. Ultrasound KUB, sir.
Brijesh, just show them.
So on general examination, everything was normal. Abdominal palpation, there is no any abnormality. For rectal examination was also normal. And we did first urine routine examination. Urine routine showed just 1 to 2 pulses.
No, so 1 minute. Girdhar, you realize
Yes.
always from the history never jump.
Yes, sir.
Okay,
Sorry.
so
Yes,
this
I
is
will-
an important thing. Examination you have
Yes.
missed,
Yes,
and that can create a problem in the exam.
yes, sir. Yes. Thank you, sir.
Okay, so
Yes, sir.
always see examiner may ask you directly, okay, what investigation you like to do.
Yes,
So
sir.
before that also you must take it, sir, I like to do first examination and then decide regarding.
Yes, sir. Yes.
Okay, okay, fine. So in this case everything is negative,
Yes.
but otherwise what are the important things you are expecting in examination?
So examination, I'll mainly more focus any flank tenderness is there or not. Mainly the renal angle tenderness is there or not. That I will like to elicit, because if there is any signs of inflammation, like any signs of infection, I can rule out like pyelonephritis basically. But patient as there is no fever, so that could be the less likely I will suspect in this patient. And then down the line, I will like to examine the external genitalia, because my first diagnosis is a urolithiasis. So anyway, if any stone is there, if planned to any intervention, so the external genitalia, if there is any stricture, how's the meatus, how's the any BXO changes is there or not. So it will help me out in the further plan for my procedure.
We just show them investigation.
Urine culture report came to be negative. We did the complete blood count. Hemoglobin was 13.4. WBC was 200. Serum creatinine was 0.7.
पाच नंबर मध्ये URS साठी ऍडमिट त्याला NBM सांगा मी सांगितलं
गौरंग सर आप होस्ट हैं सर, म्यूट कर सकते हैं.
हो 2 दिनेश आहेत 2 नंबरचा वेगळा 5 नंबरचा वेगळा
His serum creatinine was 0.7. Sodium, potassium, everything came out to be normal. Hello.
Yes, sir.
Yeah. Okay, so these are the investigation.
Yes.
Anand, now what you want to do?
Sir, I would like to proceed with the ultrasound, sir. Ultrasound KUB, sir.
Okay,
Yes.
please just show them ultrasound.
So this was ultrasonography of abdomen plus KUB. So liver, gallbladder, pancreas were normal. Right kidney, there was an evidence of 1.8 centimeter calculus at UV junction causing back pressure changes in the form of mild to moderate hydronephrosis. Right kidney showed partial duplex pelvic cell system. Similarly, left kidney, there was mild to moderate hydronephrosis when calculus was noted over the lower calyx measuring around 6 mm. Both kidneys were larger in size and minimally raised cortical echogenicity. Urinary bladder was minimally distended and prostate was 20 cc.
Gite sir, can you just take over to them? Okay, anyway, Giriraj, now what you want to do?
So as the patient having left flank pain and followed by the right flank pain. But as we can see in the ultrasound, we can able to see 1.8 centimeter stone in the right side. That could be the cause of right flank pain. But we could not appreciate the ureter in the left ureter. So for that, I will like to go for a non-contrast CT, CT KUB, to identify the any lower ureter, any stone is there, which causing the pain on the left side, because there is a left renal mild to moderate hydronephrosis is there, sir.
So now, if it is showing that there is no stone seen in sonography, then what are the possibilities?
Sir, either the stone in the lower ureter, sir.
Yes, sir.
So the lower ureter stone generally missed in ultrasound because it is a operator dependent.
If the bladder is not properly distended, it could be missed in ultrasound, sir.
So that is one thing. What is the second possibility?
Second possibility, it could be the primary obstructing mega ureter, which is
Ureter is not dilated, na?
moderate hydronephrosis. That could be the PUJ, sir.
So your plain CT scan will be helpful?
No, sir.
No.
We need to see to urogram, sir. Demonstrate.
So now tell me,
Yes,
you summarize everything
yes,
and
sir.
tell me what you want to do.
Sir, as the patient is having bilateral flank pain and with radiating line to groin and which doesn't have any comorbidity and blood and urinary examination is grossly normal. USG showing right kidney, duplex kidney and left kidney, even though there is non-obstructive stone in the left lower calyx, but patient is having left flank pain. So I would like to proceed with the sir CT KUB, sir. CT KUB contrast rather, urogram.
Okay. Fine. Vijay, show them. See all the films properly.
Yes.
Okay.
Yes.
And then analyze and now answer after that. So who is going to answer first, Anand or Giriraj?
So in the CT, I just is there any picture for any delayed film? Is there?
Actually, patient had brought this CT plates from outside. He had done not in our institute. So this was all the reports we could have.
Okay. So initial picture which is showing is a contrast enhanced CT which show the axial cuts. Can you go back, please? Yeah. So it's a contrast enhanced CT which showing the axial cut and which show the right side hydroureteronephrosis with the left side VUGCal, and that's a parenchymal thickness is good. On the left side, there is a pelvis is dilated, but ureter is I'm not able to trace down. It's could be normal. Bladder appears to be normal. There is no bladder thickness or there is no any other growth. other organs like liver and spleen and other organs appears to be normal. There is no any other mass in the bilateral kidney. Yes.
So this was answered by Anand, correct?
Sir,
I mean, by Giriraj.
yes, sir, yes.
So Anand,
Yes, sir.
how will you describe this city in example?
It is as a contrast city of abdomen and pelvis, sir, showing right kidney is showing hydronephrosis, and left kidney
To
is
talk about, you don't want to talk about in short about other structures, solid organs and other things.
yes, sir. The kidney, liver, spleen is grossly normal, sir.
Okay. Okay,
The right
fine.
kidney is, sir, hydronephrosis and mild fullness of the left kidney, sir. In the left kidney, sir, I don't find I don't make out the ureter, sir. And right side there is a stone in the VUJ.
Fine. See, whenever, if all the films are not available,
Yes, sir.
there are two you can ask. One, you can ask the examiner that please, I will like to see all the films. And
Yes.
if the other films are not there and it is not very conclusive,
Yes, sir.
then you should ask for the report.
Okay, sir.
Gite sir, will you like to give some comment on that? Dr. Gite?
Sir, please unmute Dr. Gite, sir.
But he's a co-host. Gite sir, you can unmute yourself.
So no, sir. Please continue.
Okay, fine. So show the report.
So the report suggested of around 22 cross 18 mm size calculus around right VUJ with complete duplication of right PC system and right ureter is noted. Moderate to severe hydronephrosis involving right mid and lower pole calyces. The ureter draining the right lower pole calyces showed moderate dilatation. 11 cross 9 mm calculus noted in this ureter at the level of iliac vessel crossing. The ureter draining the upper pole calyces showed mild dilatation. The right upper pole calyceal shows mild hydronephrosis. The right kidney shows normal contrast enhancement. Prompt contrast excretion is noted in the upper pole calyces. 5 to 10 minute delayed contrast excretion with hold of extruded contrast is noted right mid and lower pole calyces. Mild to moderate left hydronephrosis is also noted. The left ureter is not dilated. Left renal pelvis measures 24 mm. And left kidney shows normal contrast enhancement and prompt contrast excretion. The ureter is not opacified at 10-minute delay scan, and there was a 7 cross 6 mm calculus noted in the left lower pole calyx.
Fine. So Anand, this is the CT scan report. So now what you want to do? How will you go ahead?
Sir, the patient is having duplicated system on the right side, sir, and a stone, one stone in the right VUJ and other is at the level of iliac crossing. And on the left side, there is a mild fullness of the PCS, and there is an incomplete VUJ obstruction on the left side, sir. So I would like to proceed with sir, for confirmation of this incomplete PUJ obstruction, sir, I would like to do DTPS scan, sir, so that I would have some gross idea about the baseline function of the left kidney, sir. So it will be helpful me for the further follow-up and yes, sir.
Okay, fine. So just show them, please, what we did. Show them radiograph.
So left kidney was normal configuration, comparable size, no abnormal areas. There was prompt uptake of the tracer with the rapid excretion as renographic curve is a non-obstructed pattern. The right kidney shows a duplex system, all normal in size with an overall good cortical tracer uptake. The upper moiety shows good tracer uptake, extraction with rapid clearance. Osteopenia is seen in the regions of dilated pelvis. In the regions of lower moiety that fill-ups doesn't show significant tracer clearance during the dynamic imaging. Renographic curve is intermediate pattern of obstruction. And right-sided shows duplex moiety is noted and the upper moiety has good function with a non-obstructed drainage. The lower moiety has cytopenic relatively reduced cortical function and obstructed drainage.
Yes. Anand. Now, what is the total conclusion from all the investigation?
So there is a partial PUG obstruction on the left side, sir, and on the right side there is a complete duplication of the PCS on that too. The lower moiety is obstructive and having stone. So I would like to intervene the right side kidney first, sir. On the in the same setting, I would like to put a stent on the left side, rather, putting a stent on the left side, sir. And yes, sir. Follow. Now for the right side, sir, the obstructive system, I would like to operate first.
Which one?
Lower moiety, sir. Left, right, lower moiety. And in this case, serum create and CBC is completely normal. I will go for the complete clearance. I will remove the BUHKL on the right side also, sir, and putting a stent on the left side, sir.
Gite, sir.
So,
Dr. Gite. I think Gite, sir. Has anyway, Hiren, you want to add something?
sir, as I have a different opinion regarding what Anand told. As the patient having left kidney as a good cortical function and non-obstructive drainage, so I will not like to intervene the left side because I will follow up with the consecutive ultrasound scan show with the APD diameter and parenchymal thickness in the follow-up scan. If it needed in the future, if it is like APD is increasing on parenchymal thickness is decreasing, then only I will think about intervening the left side kidney. On the right side, which is a duplex, and the both moiety, upper and lower moiety, which is obstructing with a stone, that I will like to intervene as the patient creatinine is normal and there is no infected system. There is a urine routine also pitched to normal. So I will like to clear in a one setting in the both moiety and like to put a stent.
Now, you tell me what was the presentation of this patient?
Presentation with sir, left
Bilateral
pain.
flank.
Yes, sir.
Bilateral flank, sir.
Yes.
So he has got a pain on the left side. You don't want to do anything on the left side?
But there is a draining that system, so I like to be follow up because it's not obstructive and that's what.
Yes, Anand.
Yes, sir.
So what is
Sir,
your
I would
say?
like to dial. Sir, I would like to put a stent on the left side, sir, also by this serial ureteric dilatation and putting a stent on the left side also.
Dr. Hudedar, can you just comment on this? Okay. So left side, one of you are saying that you will like to put a DJ stand.
Yes.
Okay.
Yes.
So why you want to put a DJ stand? Why you want to put a DJ stand?
Sir, it is having partial pH obstruction, sir. Rather end of pilot stent, sir, that will be more helpful.
No. So what is the purpose? So you want to see after putting a stand whether the pain is he is getting relief from
Relieved
the
or not,
pain or
yes.
not. So if he is getting a relief from the pain, then what will be the next step for the left side?
Sir, after 4 to 6 weeks, I will remove the stent, sir, and keep that patient on the serial follow-up, sir. A repeated DTP scan and CT scan, sir. If the function is slightly improved or remains same, I will just keep the patient on the follow-up, sir. If the in the repeated DTP scan and CT scan, sir, I will found the function is decreasing, then I would like to intervene that patient, sir. So I would like to go for some definitive management, sir, in the form of pyeloplasty.
Suppose this patient he gets relief and the pain disappears, but after removing of the stent, again if he gets pain, then what you will do?
Then it is an indication for surgical management, sir. I will keep this patient for open left pyeloplasty, sir.
Do you suspect that this dilated system, even though it is non-obstructed, there are chances that this small stone on the left hand side in the lower calyx might be coming and causing obstruction and pain?
It could be the possibility, sir.
Slightly, sir. Yeah,
So you
could be the
don't
possibility.
want to do anything to this left-sided stone?
Yes, sir. Then I will do ESWL, sir. That is for left side.
So the ESWL will help in this lower calyx and hydronephrotic kidney.
Sometime back you said you're
Sorry,
going to
sir,
put a
sorry.
stent. Now when you're
Sorry,
doing
sir, sorry.
intervention, then why you want to do ESWL?
No, sir, no, sir, no, sir. RIRS, sir.
Then we
100%.
talk what is being done nowadays. Now who's doing ESWL? You are saying that I am going to put a stent because patient is symptomatic and you are going to have a stent. Then when you are going to put a stent, remove the stone also, no?
Yes.
Simple 6 mm stone RIRS can easily tackle. Why you want ESWL again? Fragments will be there. It will not clear or whatever.
You
Yes,
are
sir.
understanding that, right?
Yes, sir.
So now tell us what you will do. Summarize everything and tell us what you will do on the left side.
Sir, I would like to this completely stone clearance on the right side in the form of URS, sir, by both multi, sir. And on the left side, I will do RIRS and put a stent, sir.
Now,
For left
okay. So on
lower
the right hand side, this patient has got both the stones since last 4 years. So before we go ahead, what is this law regarding the
we get made
double?
law, sir.
Yeah,
We
tell us.
Mayor rule, sir, is
We
asking.
get made law. We
upper
get
Tell
made
me.
law. The upper and lower
One of
multis,
you, Anand.
lower multis.
Yeah.
Yes, sir.
Giriraj, you are saying you say
Uh,
properly.
Sir, I will say, sir, the upper and lower moiety, sir, depending on the opening of the ureter, sir, the lower moiety is orthotopic in location, and the upper moiety, it is slightly medial and more obstructive, where the lower moiety is more refluxing. That is Wiegert linear flow, sir, seen in complete duplication of the system.
So what is the
And
terminology used for complete duplication for the ureters? It's called double ureter.
Yes.
So when it joins somewhere in the middle, then it is a bifid ureter. But
Yes.
when there is complete
Bifid.
duplication, then it is called double ureter.
Yes.
In the beginning, you guys were saying that we'll do NCCT KUB, but from my experience, once even Gaurang Shah sir had come for that case. So there was a patient who was operated outside, and they went into the left ureter and they could not see the stone because they had not done a CT urogram. And
CT
patient had complete duplication with 2 ureters and 2 moieties, and the stone was in the other ureter.
Yes.
So you have to be a little bit careful when you say non-contrast CT KUV. So sometimes if it is a simple stone, straightforward case, it's okay.
Yes.
But urography always gives us more information.
Yes.
And sir is right,
Yes.
now when there are 2 moieties and 2 ureters, and how you will tackle, how you will explain the patient. So overall summarize the case now. What is happening here?
Yeah, summarize the whole thing. Yes, Anand, can you just summarize the whole thing and you tell me how to go about?
Yes, sir. Patient is having bilateral flank pain, and blood methylation and urine return is normal, sir. Means, so we can go for definitive treatment, sir. On the right side, we will go bilateral URS, sir, and on the left side, we will go do RIRS and put a stent for the lower calcium stone, sir.
So before doing RIRS, will you do something? Will you assess the ureter? How will you assess the ureter, whether it is
Sir,
possible?
CT urogram, sir.
No, that is done now. That is done. Will you tell the patient that, okay, I'm going to take you for RIRS? So what is the success rate? Do you know something called calibration? What is calibration? How will you
Calibration,
assess?
sir. So
How will you understand whether you can do the RIRS or not? Before putting RIRS scope, will you do something?
dilatation, serial dilatation of the ureter.
Whether dilatation should be done or something else should be done. Endoscopic dilatation. What is endoscopic dilatation?
Final.
So first you will put in a 6 by 7.5 French ureteroscope. If that goes in, then you will understand that maybe a 9 by 11 access sheath, 9.5 by 11.5 will go in.
Yes.
Usually if the 8 French URS goes in, then 10 by 12 access sheath can go in. So whenever you are doing RIRS, first thing is calibration. You have to see how the ureter is. If the ureteroscope is going in easily, you will attempt it. If it is not going in easily, there is no role of dilatation. You should just put in a stent and come out.
Come out.
So
Yes.
these things you have to talk to the patient, no?
Yes.
You have to talk about the success rate and you have to explain him that 95% of the times we manage to go in, but in 4 to 5% of the cases, if the ureter is tight, we will not be able to go in. Understood?
Yes.
Yes, sir.
So now one more thing I wanted to ask you is that which are the cases where you can predict that the ureter will be good? Is there any way you can predict?
Like in female patients, sir, we usually can like
Okay, so the urethra is minused in that case, so maybe that is a good case.
yes.
Then elderly patients,
Yes, sir.
then patients with previous history of ureteroscopy,
Yes.
Pre-stent
then
test.
patients with lower ureteric stone and renal stone. So you know that lower ureteric stone ureter will be dilated, right?
Yes, sir. Yes.
Yes, sir.
So these are some of the cases where previous history of ureteroscopy, previous degestenting, lower ureteric stone, old patient. These cases, the ureter will be dilated.
Yes, sir.
Okay, what is an exception to the Wiegert-Mayer guessing law?
Exception.
Paras, can you answer?
Are you all aware that there is an exception to the Weigert-Mayer rule?
Sir,
Yes,
we
sir.
have to unmute Dr. Paras.
Uh-huh.
Paras, you can unmute yourself. Paras.
I am back.
Exception to the vigor
No, Paras, we can't hear you.
mere law is Stephen ectopic ureter.
So what is the Stephen ectopic ureter? So instead of opening
Hello.
medially,
So the exception in this it opens superolateral.
exactly. So then instead of obstructed, it
It
becomes
opens
reflective.
superolateral to the lower
Yeah,
moiety.
yeah. So instead of it being obstructed system, it becomes a reflexing system. Okay. So that is the thing. Okay. So now the problem was that this patient had this stone since last 4 years and it was totally obstructed and stuck. So we could remove the lower moiety calculus, but it was very difficult to, as Dr. Hiren Sodha said, to go into the upper moiety. So we had put the double J stent. So this is again one of the indication which shows that it may be difficult because if it is a long standing calculus with a infection, recurrent pain, there may be usually some fibrosis around the stone, and that is the reason it becomes very difficult.
Plus,
So
with these
previous,
double ureters, one ureter may be very good and one may be a little narrow. Many
yeah,
times we see that. So
correct.
what sir is telling is if there is a narrowing, then you don't force yourself in. You just put a stent so that
Yes.
you will be safe.
So Brijesh, do you have any video of that?
No, sir. At present, I don't have.
Okay. So when we were doing URA, okay, there was like a growth, mucosal polyp type of growth, not actually like malignant, but it was coming, hiding the full stone, and we were not able to even the dilate below the stone also. So first time we tried to do URS, it failed. Second time also we tried everything, but because of that growth, we were not able to see the stone. And even if we see the stone, try to break it with the lithoclast or with the thing, thulium fibers. Okay, we had to go little distally, and that flap used to come in the way. So second time also we were not able to get the stone. So now what we will do, Anand? This is the situation.
Sir, after a repeated attempt of URS, you are failing, and if the upper moiety is in ectopic location, so other option is, sir, and the patient is having persistence in symptom in spite of the stent also. So other option is, sir, the uretic reimplant of that upper moiety, sir. So the same settings.
बेटा
At
पहले
that
स्टोन
time,
तो निकालो ना. Sir is saying
yes, sir.
stone ही नहीं निकाला.
Yes, sir. It's laparoscopy guided stone removal and uretic implant in the
So
same
first is
settings.
ureterolithotomy, na.
Oh, yes.
It can happen or no. Many times it can happen that 2 URS attempts have failed. Then what you will do? Directly you should not say uretic reimplant, no. Maybe it's in the mid ureter. You don't need to do reimplant. You can just
Yes, yes.
remove the diseased part of the ureter and do a ureterostomy.
Ureterostomy, yes.
So unless it is a long segment stricture, you may need a reimplant. But why do you want to reimplant unnecessarily?
So now tell me, what are the different ways of doing the ureterotomy, and what is the difference between a single ureter and this double ureter? Anand, can you tell me?
Sir, different ways, sir. Either open approach, sir, then
Okay.
laparoscopic, robotic, but in our institute, sir, means we do open only, sir.
Okay. So you will like to do open. So what are the
Opens.
things you are anticipating? Looking at the CT scan.
So the way to answer this is that I will give the options to the patient.
Patients,
I
yes,
will
sir.
explain the options to the patient
Option to the patients.
that there is a ureteric stone and we are not able to manage it with URS. So now we have to do either laparoscopic, open or robotic. All options are there.
Yes, sir.
However, at my institute, sir, we are used to doing open surgery. And if patient wants the other two options, then I will give, I will maybe refer or call a
Higher centers.
person, call some senior to help me. If you tell like this in exam, you are safe because you have discussed the options with the patient.
Yes.
Every case, you must discuss the options with the patient. What
Fine.
examiner wants to see is that how safe you are and whether you have discussed everything or not. Huh?
Yes, sir.
So yeah, it's fine. Okay. So what are the difficulties you are encountering in this case? Where is the stone exactly lying? Where is the ureter? I mean, where,
Exactly.
what is the important relation of this stone with the structure?
West.
See, CT scan is saying it is lying over the external iliac vessel.
Iliac artery.
Yes,
Yes.
yes.
Correct. So now what
Yes.
you anticipate? Because it is a long standing, there will be fibrosis. You are already done 2 times URS. There may be extravasation. Correct. More of the
Yes, sir.
fibrosis
Not
adherent to
fibrosis.
the
Adhesions.
structure of the vessel.
Yes.
Bleeding
So
and
you have to
adhesions.
be, yeah.
Anticipating the bleeding during the procedure, sir.
So one is,
More
so you
than the
like to,
bleeding, you have to say that you may have to separate the ureter very
Ureter,
carefully from the iliac
ureterolysis.
vessels,
Yes, sir.
and
so,
you have to
yeah.
identify the correct ureter, right? There are two ureters, no?
Yes, sir. Yes.
Yes, sir.
These are the two things.
So one is you have to separate it very carefully, and second is, yes. Third thing is the whole thing may be fibrosis and little hard.
Yes.
So you may not be able to palpate stone very clearly
Yes, sir.
in this case. Okay. So that is the another thing. Okay, fine. So you will like to do urolithotomy. Now we have done urolithotomy and we have put the stent. Now what you will do?
We will.
Sir, after doing ureterolysotomy, I will put digestant and I will keep one drainage tube near the anastomotic site, sir. And also, I will maintain the low pressure system, catheterize the patient, sir.
Fine. You have done all these things. Patient has gone home. He is fine. Now when you will remove the digestant and how will you follow?
Sir, ideally I will remove the digestant after 6 weeks, sir. And in our institute, before removing the stent, sir, we used to do RGP to see the anastomotic site, sir. If there is a no leak, we'll remove the stent, sir.
Okay. Anything else before removal of the stent?
RGP,
So RGP is okay, you will assess the anastomosis, but the best way is to do a functional study, right? You have to see
Yes,
that there is no obstruction.
yes, sir.
So whether you do RGP or you do CT, both ways you will not get the answer. Best
Yes.
is to do a functional study.
Yes.
You want to
Yes,
see
sir.
that the renal function is preserved and the drainage is good.
Yes.
So DTPA should be the right answer, in such cases, because here medical legally also you have to be safe, right?
Yes, sir.
Yeah.
So normally what we do is that we do the ultrasonography before removal of the stent. So we know what is the level of hydronephrosis. Okay.
Yes.
And then we remove the stent, then see the patient, as you are saying RGP, that's okay. But before that, whether there is any infection or not. If there is infection, better to treat it and then go for a removal of the double
Stent.
J stent. Right?
Yes.
So now when you remove the double J stent, you might have done RGP, whatever it is, and DTPA scan. But important thing is how you are going to follow up. So you will look for infection, you will look for pain, and you look for ultrasonography,
Yes.
demonstration of hydronephrosis. And as
Yes.
Dr. Hiren has said, next will be functional.
Function.
So all these
DTPS.
things are abnormal. You will definitely like to repeat the DTPA scan to see whether obstruction is increasing, whether the function is deteriorating. Now everything is fine and the patient is okay, then you may not do any reconstructive surgery. But suppose now this patient, we have just put a DJ stent, we are going to remove. After removal, if we find that that segment is obstructed, now what you will do? Anand, what you will do?
Sir, even after doing ureterolectomy, if it is on the stone is on the lower side and still the patient is showing obstruction, again I will want to do put a stent for 4 to 6 weeks, and again I will reassess the patient in the form of DTPA. In spite of all, and again the function is deteriorating, I will go for uretic reimplant, sir.
So medium.
So what? Yeah, tell me. What do you want to say?
So it's a mid-ureter stone what we are dealing with.
Yeah, so what do you want to do?
Boa reflex, sir.
Is in the form of big Bohari.
Why you want to do Bohari? You know one thing, whenever you do reimplantation of this double moiety ureter,
Yes.
you cannot take one ureter
Yes.
because the blood supply is from the
Common
common sheet.
sheet. Yes.
So if you separate them, what will happen? One of the ureter will lose the
blood supply.
and it will get necros. So you have to do, even if one ureter is normal and
Yes.
another is abnormal, you have to do common sheet reimplantation.
Yes.
This word was required from you, common sheath. That is
Common
what sir
sheath.
was looking for.
Okay, sir.
So this case is special. That is why we have presented it. Just for you to make you think that right from, whether doing a non-contrast CT or how to manage the ureter and what can happen, problems, and
Yes.
what if you put a stent and there also it doesn't dilate. So that's why so many scenarios in this case.
Yes.
Right? So either you can do con, but this is little high, and the second ureter is quite normal.
Yes.
See, common sheath reimplantation is done when the obstruction is, or there is a mega ureter, like in refluxing or obstructing ureter. So it is very near to the bladder and it is intramural part. Understood?
Yes.
But here it is much higher. So what are the other options? You said very rightly, na, earlier.
Boa reflex, sir.
Why Mohari flap? You can do ureterouretic anastomosis, na?
Yes.
Yes, sir.
You can do side-to-side anastomosis,
Yes.
and you can put the stent across and see, because both the ureters are dilated because of the stone. So you can always try that. That's the first thing. And then again follow up. Correct?
Yes.
Yes.
Okay? Fine. Okay, so we'll go for a second case. Brijesh, show the second case.
A 69-year-old male present with a complaint of pain over right flank since 3 months.
Yes, fast.
So he was asymptomatic before 3 months and had developed a pain which was colic in nature, sudden onset, radiated from loin to groin, relieved of taking analysis. No hematuria, no fever chills, no any instrumentation, no any bleeding disorders, and no any blood transfusion. He was known case of hypertension and diabetes since 10 years. His examinations were normal. Local examinations were also normal. Grade 1 prostatomegaly. And these are the investigations. Create
Okay,
was
Anand.
Yes, sir.
Anand, yes.
Yes.
Just see the report and tell me what you will like to do now.
Yes, sir. The 69-year-old male with diabetes and hypertension, sir, and having loin to groin pain. My possibility differentials are, sir, stone disease, sir, and the patient is also having diabetes, renal papillary necrosis, so for papilla also I will keep in mind, sir, in a renal cystic disease, and for the confirmation of it, I will want some renal sir, in the form of USG abdomen.
Yeah, show him. Brijesh, is that we have done the sonography?
Yeah, he had outside report, old one.
Just show.
The USC suggested that right kidney was appeared enlarged and there was mild thinning with moderate to gross hydronephrotic changes and hydroureter due to a there was a calculus of 14.8 mm in the right upper ureter.
Okay. And
left kidney there was an evidence of 10 mm calculus in the mid pole. Prostate was 20 cc. Prevoid and postvoid is subdued.
fine. So, Giriraj, now what you want to do?
So this ultrasound shows right side mild cortical thickening with 4.8 mm calculus in the upper ureter with grossly hydronephrotic changes with hydroureter. So it's a I will like to it's a grossly hydronephrotic kidney with mild cortical thinning. So I will like to check whether how much the cortical how much is the whether kidney is how much is contrast uptake or draining is there. So I would like to go for a before intervention. I would like to go for a CT urogram in this patient, sir.
So you have to describe it as a functional as well as an anatomical study.
Yes,
So
sir.
CT is going to be an anatomical study.
Yes,
It
sir.
will give you a rough idea about the function and the cortical thickness.
Yes, sir.
But later on, you may want to quantify the function. So
Yes.
you have to use the right words, okay?
Yes, sir. Yes.
So you do anatomical study at the same time you assess the whether it is taking up the contrast and what is the actual thickness of the parenchyma.
Yes, sir.
And then for documentation, maybe you want, okay?
Yes.
Also,
So-
there is something on the left side which you have not mentioned.
There's a non-obstructing calculus of 10
Non-obstructive 10 mm
mid-pelvis.
mid pole.
So don't you want to see on CT how is the pelvic system, how you are going to approach this stone?
Yes, sir.
Yes, sir.
Yes, sir.
Now, it is very important in this case because one kidney is little bit damaged.
Yes, sir.
The other kidney is very good.
Yes.
So you have to make a passing comment when you are talking about the CT and all that. I would also assess the left side because I'll have to offer him, explain him that there is a 10 mm stone. You don't want that 10 mm stone to become 3 centimeters, no?
Yes, sir.
Yes, sir.
Okay,
So, what
go
is
ahead,
this creatinine level?
1.6, sir.
So, you want to do
Slightly on the
contrast
higher
or you
side.
want to do plain?
Sir, CTK urogram is accepted up to, sir, 1.7, 8 or 1.8, sir.
Yes, sir. We can hydrate the patient in
Patient and also-
higher and yes.
So,
And
what is
I
more
would
important?
like
So
to-
Yes.
first thing is to say that every institution has their protocol.
Yes, sir.
You can say that my institute, we are up to 1.6, we are doing whatever you said.
Yes, sir.
But and don't say we will hydrate. We nahi. I will suggest that the patient, the
Okay.
patient should be hydrated well.
Okay.
And you want to give anything to protect the kidneys?
Yes, N-acetylcysteine, sir.
Very good. So capsule mucinex, N-acetylcysteine, 600 twice a day for 3 days.
Yes.
Yes.
And hydrate the patient well, and then do a CT.
Yes.
But it's surprising that CT is creatinine is 1.6 because left kidney is non-obstructed, right?
Yes.
Yes.
So you have to think why
What is the cause?
creatinine is 1.6. Yeah.
Why creatinine is high? Yes, Anand, can you tell
Sir,
me
the
the reason?
there may be chances of urosepsis, sir, or there's
One
a
is
complete
infection. Chalo,
Yes,
one
sir.
is an infection.
Patient is already diabetic, so it could
Correct.
be
You said it in the
diabetic.
beginning, diabetic
Yes,
patient. So
yes,
comorbidity is already there, right?
yes, sir.
Yes, sir. So
So
there
one
is
is
He
a
might be
chance of
having,
comorbidity, second is
urosepsis.
infection.
Yes,
Yes,
so
complete
he might be
obstruction of
having
the lungs.
underlying medical renal disease due to diabetic nephropathy.
yes, sir.
Yes, sir. And he was also having hypertension also.
Yeah, and the hypertension. So because of this
Yes.
comorbidity.
Yes,
Fine. Okay. So now if the patient, you see, normally we go for a GFR
yes.
rather than creatinine. So in this case, GFR will be definitely less than 40. Now, will you like to do CT scan,
What is the CKD
CT
classification?
IVP?
So, sir, I will do MR urogram, sir. MRI urogram. That will be more
No,
safer.
suppose if
Sir.
you do plain CT, then what, for the function, what you will do?
If sir, on the plain CT, sir, if I would able to make out there's a good parenchyma thickness on the left side as well as right side, so that will give me the baseline idea of the cortical function is
But
good,
sir's
sir.
question was, how will you assess the function?
EC.
Why don't you answer that correctly?
Yes, sir. EC scan, sir.
Yes,
So is there any limitation of creatinine for doing a functional study?
No, sir.
So you say that, na?
yes,
So you have to be very specific in exam. If sir is asking how will you assess the function, then you don't talk about cortical thickness and all. Is that the way to assess function? No. We have to be scientific, no? So we'll do a functional study to assess the function.
Yes.
yes.
What is the CKD classification? Sir mentioned something about GFR.
So,
Mm.
60 to 80. So more than 90 is normal. 60 to 89 to then 45 to 59. 3B is 30 to 44. 3B 4 50 to 29 and 5 is less than 15. Sir.
Very good. So if at all his GFR is between 40 and 50, then he is already in CKD3.
CKD.
Yes.
चलो अब ब्रिजेश भाई बताइए आगे क्या किया?
So this was a CT scan.
Yes.
So what do you think from the CT now? Are you getting some idea about the parenchyma?
Yes, sir. There's a gross. Yes.
There is gross, but it's not completely gone, right?
Yes.
Yes.
There is a removed tissue at the upper pole.
Yes, sir.
Mid pole is maximally affected.
Yes, sir.
But there is some tissue at the upper pole and little
lower
bit
pole.
at the lower pole.
Yes. Yes.
Now, in such a patient where the overall global GFR is reduced, would you like to save this kidney?
Yes, sir.
So now, do you want to document the function?
Yes, sir. I would
Why?
like to.
Why?
Sir, for the further prognosis, I will explain these things to the patient also. And for the
So there are two
further
or three
follow-up and
reasons.
prognosis.
First is
Correct. So
one is the medical legal aspect of this.
yes, before
yeah,
intervention.
so there are two or three reasons.
Yes.
One, you would like to have a baseline function at this point because he has a creatinine of 1.6.
Yes.
Second, to follow up this kidney which you are going to treat,
Yes.
the right kidney. And third is the medical legal aspect. So patient may turn around and say that my kidney was normal, you damaged it. So therefore, for these three reasons, we have to have a documented function. So on the left side, do you see the stone?
Yes.
Yes, sir.
Yes, sir.
Will you be able to manage it? With RIRS?
So Anand, let us now start. How you are going to treat this patient? Just show the renogram, DTPS scan, Brijesh. So the right is,
yeah, 43.
GFR is
23, sir. Sir, this keeping the creatinine of the patient is 1.6 in mind, sir. So I would like to do, sir, a DG stenting first on the right side, and for the yes, sir, DG stenting on the right side, sir. And I would like to follow up the patient. Once the count and create comes to normal, I would go for definitive management on the both sides, sir. Especially the on the right side, right
no, no,
flexible
why you want to do digest stenting? What are the
because the
indications
creatinine,
of digest stenting?
What is the WBC count? You're saying count and creatinine. I missed that. What is the count?
sir, 10,000 or 11,000.
Counts is
Then
no.
patient is not in
Yes.
sepsis. Then why you're telling that I would like to put a DG stent? If patient is sick and he is in sepsis or his blood pressure is down and the kidney is filled with pus, then I can understand that you will put a stent.
Or if you are doing, you decide to do URS or RIRS, and
So what
at
you are
that
going to
time,
do for this case now? What are you going to do?
now
What is
tell
the
me.
plan?
Yeah.
What is the plan actually? You tell me and sir, what is the plan now?
Sir, right-sided RIRS, sir. I will plan this patient for right-side RIRS.
You have to
If
say URS with RIRS, no?
yes, sir, URS with
Because first you will go
RIRS, sir.
ahead with the ureteroscope. It may be stuck
Ureteroscope.
there, badly edema there.
Yeah, sir.
Directly
Then just I
RIRS,
will
no.
keep a
But if you
stent.
cannot reach, then flexible definitely will help you. But first URS, SOS pushback, RIRS.
Yes, sir.
It's not
And
so easy. When the kidney is dilated, na, RIRS becomes more difficult.
You can keep the option of pushback.
it's a pushback PCNL also. I will keep this option open, sir.
PCNL, see, again, you're going to damage the parenchyma. Here, you want to save every nephron. If it was a very large stone, I could have understood PCNL. It looks manageable by URS with RIRS.
So I will give you a story history that this patient refused everything and he said he wants to do ESWL. Will you like to do ESWL on this patient? Anand,
No, sir. On the right
So
side.
what would be your explanation? Now patient is telling I want ESWL. How you are going to explain him?
So this on the right side, there's a ureter is completely obstructed and there's a gross hydronephrosis. The success rate of ESWL is
The chances
less,
of the residual fragment will not.
No, your answer is not complete. So I want 3 or 4 points what you will explain to the patient. Number
So
one, you
the-
said his stone is impacted. Okay. Number two, you
Yes.
said success rate of ESWL. Okay. Number three,
And also, I will explain the patient that even though I'm going it to giving ESWL, the chances of the clearance of the stone is lesser.
why in this case? Why? That is what I'm asking. You did some study just now, no? What is the GFR?
Yes.
This right kidney is a poor functioning kidney, no? Will you have good
Yes.
diuresis?
No, sir.
You need good diuresis for the stone fragments to clear, no?
Yes.
Yes.
Clear. Yes.
Plus, there could be edema at the site of impaction.
Yes.
Even if you push it inside and break it, will those stone fragments come out from that area?
Yes.
So what may happen? So you have to explain him that one, there is a bad impaction which has caused so much hydroureteronephrosis. Secondly, it's a grossly dilated system.
Yes.
Thirdly, the function of the kidney is poor. And fourthly, he may require ancillary procedures for stone clearance.
Yes. RIRS.
So it would be better to do the stage 1 only, that you can clear it with laser and powder it completely, or pushback and PCNL. Both
PCNL,
options are
yes.
better than ESWL, definitely.
Yes.
so there are two
And
more things
also,
to
you
this.
need to treat the left side.
Left side
Yeah.
also. RIRS.
And apart
Sir was
from
saying
that, there are
something.
another two important points. If you are regularly doing ESWL, you'll come to know. First of all, this is a, I think, 1,500 Hounsfield unit.
Yes.
It's
The
a very
stone is
hard
hard,
stone.
sir. Yes, sir. The lesser chance of breaking.
Yeah. Second thing is, if you go to see, it is very lower down. So, can you see? It is coming down. So, localization may be difficult.
Yes.
You understand?
And
So, many a times,
because sir is telling this, I'll tell you one more thing. At this point where it is impacted, now you should not give ESWL. It
Yes.
will damage the ureter further. So definitely a pushback is required, and pushback may not be simple. You may have to laser a stone to push back it. So when you're already going to use laser, then why ESWL? So these are the points you have to explain the patient.
Patients.
If
Sorry,
it
I
was
missed the
700
discussion a
Hounsfield,
bit, Hiren.
yes,
I
sir.
missed the discussion a bit. Are we discussing ESWL on right side?
No. So, sir, Gaurang Shah sir said that the patient wanted only ESWL.
Okay.
So we are asking the students what would be the points against ESWL in this case.
Right. Okay.
Because it is a long-standing impacted stone, sir. The function of the kidney is poor, and
Right.
he's a diabetic, and he also has a GFR of 43 with a creatinine of
No,
1.6.
I have been seeing the reports, but just
जी
बीच में call आ गया था, तो I missed the question in discussion.
जी जी. So we are just the patient wanted ESWL, so we are discussing factors against it and how we will convince him that not to do ESWL, rather choose URS with RIRS.
so unfortunately, he demanded ESWL. Anyway, I gave him totally 3 sittings because he was insisting on that, but it never succeeded. So now, next, what we like to do? URS, RIRS, mini PCN. Giriraj,
Yes, sir. As sir just now said that we can with the URS we can just break with the stone and then we push the kidney and then we can powder it with lasers.
is it so easy to? The stone is there for more than, I think, 1.5 to 2 years, and then we have already attempted by ESWL. What are the chances of this stone being pushed back? And what are the chances that with ureteroscopy, see, there is a curvature also.
Yes.
All these things, when you repeatedly do ureteroscopy or RIRS, you will come to know. Dr. Maheshwari, what is your experience in all this?
You see, in this patient who has got a massively hydronephrotic kidney with a poorly functioning kidney, I would want to choose a treatment wherein we can fragment and evacuate the fragments at the same time.
Yes.
Okay. In RIRS, whatever best you do, you would be able to dust the stone, but you will not be able to pick up all the dust.
Yes, sir.
So the best way to clear the stone will be by a PCNL or an antegrade ureteroscope.
Yes.
Okay. So with such a hugely dilated system, you see, you really need to be an expert to do a good RIRS here, because once you get in and the system drains, the system will crumple, and then going from one part of the kidney to other part also sometimes becomes difficult. So if I go back a bit, sorry, I joined late. There was a USI council meeting today. If I go back a bit, in this patient where we have an obstructing upper ureteric stone with reduced function, I would initially put a nephrostomy tube, let the kidney function, infection, if it is there, settle down, and through the same tract remove the stone. Okay. So you do not need to really think about RIRS, pushback, ureteroscopy, or ESWL in this patient. This patient is ideally treated only by two modalities. One will be a mini PCNL, and if somebody is not good or does not want to do mini PCNL, then a lapallolithotomy or a ureterolithotomy. So these are the only two ways you can really clear this stone. Ideal would be mini PCNL.
Yes.
See, what Dr. Maheshwari is saying is absolutely right. One, the fragments, because there is whatever you say, there will be a fibrosis, there will be a narrowing, and you will not be able to do anything. Okay.
Yes.
And second thing is we have to remove all the pieces because he is a diabetic fellow.
Yes.
And because of this diabetes, if you leave behind, then there are very high chances that he will develop infection. So ideally, mini PCNL, or if you think you are good at laparoscopic urolithotomy, then do that.
Yes.
So now what you will do to the left side?
Now let me ask you, would you do ESWL for left side?
The stone is impacted and is infundibule looks narrow, sir. I would go for RIRS on the left side, sir.
No, I didn't ask you that. I asked you, will you do ESWL for left side? Why? What is against ESWL?
Yes.
I would say it's a small stone. It is not in the lower calyx. It's a better functioning kidney. It's an active patient. Less than 10 millimeter stone, Hounsfield unit around 1000. Not a very obese patient. So what is against ESWL?
Narrow infundibulum, sir.
Where is the narrow infundibulum? Rather, there is no dilatation of infundibulum beyond the stone.
No,
If
sir,
there is a narrow infundibulum,
HU,
the
sir,
calyx
sir.
beyond the stone should be dilated.
Sir, HU is more, sir.
So is at 1000 you can't break the stone?
Do you want to give a complete clearance in this case? At least the left kidney is a better functioning kidney, no?
So this is nearly a solitary functioning kidney. The right side is very poor functioning.
Yes.
So because this is a solitary functioning kidney in a patient with borderline renal function, I would want a treatment where I can give a more assured complete
Definitely.
stone clearance. So ESWL is not the choice. My choice here will be RIRS. Do you agree?
Yes.
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 Sure.
So you understood it appears such a simple case that bilateral stones are there, but yet how you are going to approach this patient and separate management for both the sides, and how what is the answer in exam you will give. This is what you have done today from Dr. Pankaj, that how to conclude that you will do a particular treatment on one side.
Yes.
So can one of you summarize on either side?
Sir, on the right side, sir, I will explain, I will discuss all approaches to the patient, sir. I will keep open the option of right PCN first, and when the system is create settle down, I will do PCNL on the right side, and also explain the patient, give you the options of right urolithotomy, laparoscopic. And on the as the function of the right kidney is on the lower side, sir. So I will go for definitive management on the left side in the form of, sir, left RIRS.
See again, Giriraj, can you compile the full answer on the right side? What you will like to do and why?
So on the right side, as he said initially, that's a long-standing obstructed stone and hugely dilated system. It could be the infected. So as we put a PC and we drain, almost will be the infected urine, and then after settling the patient as the creatinine come down, we can go with antigrade PCNL or a mini PCNL. We can do it, and on the if the and on the right side we can go for with the complete clearance option as like RIRS.
Left side.
Again,
Yes.
Dr. Pankaj Maheshwari said, what is the right treatment? Either it is a mini PCNL or it is a laparoscopic or open urolithotomy.
Yes.
And why? Why? Because that means you don't want to do URS and RIRS. Why?
Because the densely impacted stone.
So one is it is densely impacted stone.
Yes,
It is
sir.
the second thing is
second thing
dilated system.
It's a huge
dilated system. With RIRS, you will not be able to give a total
Difficult.
clearance.
Yes.
Correct?
Yes, sir.
Third thing, patient is diabetic.
Yes.
Yes, sir.
Yes,
So
sir.
if anything
Total
remains
clearance.
behind, he may develop
It will cause sepsis.
pyelonephritis.
Yes, sir.
So the PCNL will give him total clearance. Yes or no? And if there is any purulent or infected urine, that also can be drained very easily.
Yes.
So that is on the right side. Left side, what answer you give?
As the patient is moreover is a solid left right poorly functioning kidney and is already diabetic, and the function on the compromised side. So I will like to give a option which is can complete clear the stone. So there is I will like two options, either RIRS, which most probably we can dust the complete stone, and second option it can if it is that RIRS is not available in my center, I can go with a mini PCNL as well.
Perfect.
Yeah. So this is the answer you have to give.
Yes.
Okay.
Yes.
Fine. Okay.
Now on right side,
Pankaj,
if you have to do a PCNL, which
Yes.
calyx access will you take?
Sir, as the stone in the upper ureter, so we ideally as the we choose the calyx which is directly to assist to the upper ureter, which is mostly the upper calyx, which give the assist to the pelvis as well as the upper ureter. So in this patients, as the upper pole, the parenchyma is good, but we can go with the in the upper lateral calyx, we can go with that we can approach this easily with the upper ureter, sir.
Can you see the liver covering the upper pole?
upper pole.
Yeah, yes, sir.
Yes, sir.
Yes, sir.
So will you be able to access the upper pole through with the liver covering it?
Slightly difficult, sir.
Yes, it's difficult.
So then,
Middle
And
calyx
the
will be
middle calyx, sir.
okay. So when you decide the puncture, there are three things which should help you decide which access to take. One, as you rightly said, the access which gives you access to the maximum stone bulk and a straight track to it.
Yes, sir.
Second is it should be a short and a straight track.
Yes, sir.
And third is we also need to be aware of the surrounding organs.
Yes.
On left side, always look for the spleen, right side, look for the kidney. On both sides, look for the colonic shadow.
Yes.
So these are things which will help you decide. Now, in a hugely dilated system,
Yes, sir.
even going through middle calyx, you will be easily able to go down the upper ureter.
Yes, sir.
And it is not very low down in the upper ureter. It is just maybe from just below the PUJ probably.
Yes, sir.
So reaching the stone from the middle calyx should be fairly easy.
Yes.
Okay. Now suppose you put a ureteric catheter
Yes.
and ureteric catheter doesn't go across the stone. And when you try to put contrast, no contrast goes across the stone in the kidney.
Yes, sir.
So then how will you make the puncture?
So usually when the contrast when the pieces is not visualized, when the contrast is not going beyond any impacted stone, then we usually puncture at just below the 12th rib at the renal angle, and then we put a 18 French LP needle and we just give a little bit contrast and visualize the system first, and then
18 French needle.
so 18 gauzes. Sorry. I'm
Gauze.
gauze. Sorry. Yes, sir.
Thank you.
Yes.
So either you can say LP needle or you can say Chiba needle.
Yes, sir. Yes, sir.
Okay. And again, how will you decide the landmark for making that Chiba needle puncture?
Just if the in the center the USG is available, that is much better. If but in our center there's a USG is not available. So in which we used to do 2 centimeter lateral to the midline and 1 centimeter below to the 12th rib. We're putting a LP needle and we try to aspirate the urine. If it's clear urine is coming, then we'll give the contrast.
No, Giraj, you see, you have a CT scan. You
Yes.
can mark where you can go for the renal pelvis.
Oh,
You sit in the console, calculate exactly where the skin puncture should be
yes, sir.
in the transverse and coronal images, and you know where to puncture. You do not need any such landmarks which can be variable in every patient.
Yes, sir. It
You
can
see,
be.
if this patient has a large liver, the
Yes,
liver may be pushing the kidney down.
correct, sir.
Okay,
Yes,
so your landmarks will go wrong. We have a CT scan, we can calculate where to make a puncture.
yes, yes, yes,
Understood?
yes, sir. Yes.
Okay, so right. Uh, would you keep blood ready when you are doing this PCR?
Yes, sir.
Yes, sir. And any patient usually get ready the blood.
Okay, so you can say that as a protocol in your center, you keep blood
Yes,
ready for every patient.
yes.
But in this patient, do you expect significant bleeding?
This patient is creatinine on the higher side, so in the raised creatinine patients, the platelet dysfunction be there, so chances of bleeding will be more in these patients. But in this patients, there is enough
Parenchyma is
parenchyma is
less,
thin, so there is a less chance
bleeding
of
is
bleeding.
slightly on the lesser side.
1.6 है ना creatinine,
Yes,
1.6 में इतना थोड़ी होएगा bleeding.
yes, yes, yes.
What happens when there is a too much
And you can
dilated
always check
bladder?
it preoperatively. Yes.
Yeah,
Sorry, sir.
whenever there is a dilated, means the chronic retention,
Yes, sir.
what happens when you drain the bladder?
This decompressive hematuria, sir.
Now here, what is that?
It's a hugely dilated system.
So remember, whenever there is a hugely dilated, even the parenchyma is seen, there is not enough of structure to hold your uh, sheath also.
Yes, sir.
Okay,
Yes, sir.
and there are very high chances that there will be some more bleeding compared to normal kidney in this case.
Yes.
So what Dr. Pankaj Maheshwari is asking is that there are chances
Yes, sir.
in this case. Even if you are puncture, everything is fine. When you puncture, there is no blood. After
Yes.
finishing, you will realize that there is a bleeding. At least I have experienced it many times. Pankaj bhai, you want to comment on that? Anything?
No, sir, I think what you are saying is right, but because the cortex is very thin, the risk of bleeding is not very high. And if this decompression bleeding is usually self-limiting. It is never severe enough to need really blood transfusion.
Yeah.
The blood transfusion is usually needed for arterial bleeding, which happens because of parenchymal injury. That risk is very low in this patient because one, there will be ample space for puncture dilatation, and the parenchyma is very, very thin. So, as a protocol, you must keep blood reserved.
Yes, sir.
But in this particular patient, if your platelet functions are normal, then the possibility of significant bleeding is very, very not very high.
Yes.
Okay. Anything else, sir? और क्या पूछना
How
चाहते हैं?
much? Yeah. How they will follow? What are the chances of stricture? Means what they will tell to the patient? Because there are chances of stricture. There are chances because he may go to the second urologist that after the surgery I have developed the stricture. So always explain to the patient that stone is long lasting. Yeah, and there are chances that he may develop stricture over time.
Structure
Yes.
So Anand, how will post say stone treatment stricture present?
So there is a flank pain. If in this setting, so there are chances of flank pain, the rising creates sepsis.
So remember, post stone treatment stricture, whether it is post RIRS or post antegrade ureteroscopy, because of an impacted stone, most of these remain asymptomatic.
Yes.
Okay, because this is a very, very gradual dilatation of the kidney. There is no stretching of the acute stretching of the perineal capsule. So there is no acute pain in these patients. So if you wait for pain, you will miss a stricture. So in such patients, as Gaurang Shah Sahab has rightly
serial
said,
follow-up.
you need to keep this patient on a regular sonography follow-up.
Yes.
So you have to very specifically tell the patient that even if he or she does not have a pain, a regular checkup is important because most strictures will not present with symptoms.
Okay.
Okay. Anything else?
So at the end of PCNL, will you place a nephrostomy tube?
Yes, sir. In our institution, we used to put PCS in every patient. Even though it's a complete clearance, we used to put a stent as well as a PCN.
So how does nephrostomy tube help post PCNL?
So post PCNL, nephrostomy is help in the first is the tamponade effect. If it is that tract bleeding, that will act as a tamponade. Second is if it is sometimes some stone get blocked the ureter or then
You have already placed a stent.
yes, sir. So in that proper drainage of the system, even though stent is there, then
We can use that tract for, sir, if the residual fragment
if
is
it is
there,
a residual, we can
can
put
use that
a reloop
tract
reloop
for
PCNL.
further removal of the stone. Reloop.
So remember, the only indications of nephrostomy tube post PCNL are if you are planning a relook nephroscopy, means during procedure you feel you may have left behind something.
Yes, sir.
If there is a parenchymal or a renal pelvic injury,
Yes.
or if there is infection.
Yes.
Okay.
Yes.
Nephrostomy tube cannot tamponade a tract.
Okay.
So you make a 24 French tract, you place a 24 French Empla sheath. The
Yes.
outer diameter of the 24 French Empla sheath is around 26 to 27 French.
Yes.
And the nephrostomy tube you place is 20 French.
Yes.
So how will a 20 French nephrostomy tube tamponade a 27 French tract?
I guess.
Yes, sir.
Okay. So never say that the nephrostomy tube is for tamponade. It is for proper drainage,
Yes.
whether for infection or anything. It is for second look
Reloop.
PCNL and if there is any injury.
Yes,
So
sir.
these are the only three indicators.
Yes,
Now
sir.
suppose you have placed a nephrostomy tube and post 48 hours you remove the nephrostomy tube, there is a persistent leak. How will you manage that?
First, I will like to check my stent position is there or not, because most of the time distal obstruction, if it is there, then the chances that tract will not close. So I like to first confirm whether a stent in a position or is there. If a stent in a position, then like in after X, usually we'll do with the X-ray KUB. If it is stent in a position, and then we'll like to see we usually to do NCCT. We'll see any nephrocute. Like sir, you're asking sir 48 hours immediately, sir.
So you have to tell me kab kya karoge.
So immediately 48 hours, some leak will be there. That will be subside, sir.
Just applying the compression.
Yes, we put a compression and just we this that will stop.
And so anything, because the patient already has a stent.
Yes,
anything
sir.
else you want to do?
X-ray KUB.
No, he has done the X-ray KUB, the stent is well positioned.
Yes.
I usually don't take out the Foley's. I always keep it.
Exactly.
Yes. Yes.
So you will
Low
want the
pressure system.
bladder to be empty.
Yes.
Low
It is
pressure
because of bladder spasms related to stent that there could be stent reflux and increased leak.
Yes, sir.
So you need to keep the catheter on. You may give antimuscarinic drugs to reduce the bladder contractions.
Yes.
Give a compression dressing.
Yes.
Keep this side non-dependent and wait. Okay, you have to just reassure the patient and wait. If the stent is there and if the passage beyond is normal passages open, all abnormal passages close on their own.
Yes.
Distally,
So-
if there is no obstruction, proximal always heals.
It always heals. So you do not need to do anything except seeing that the bladder is draining well. And as you rightly said, stent is well positioned.
Yes.
हिरेन थोड़ा RRS के बारे में पूछ लीजिए.
So, not in this case, but sir was telling that in some case where we would like to have a complete clearance,
Yes, sir.
are there any new techniques where you can ensure that the stone is completely cleared?
Fence.
Yeah, what is fence?
And that's that uric acid sheath will be the proximal part will be the flexible. So along with the scope we can take and that desired calyx where the stone we are breaking. So along with the as soon as we are breaking the stone, along with suction, the all fragments will come out. Sir.
Flexible and navigable suction access sheath.
Yes.
The challenge here is that the access sheath has to go beyond the PUJ.
Yes.
So it has to be it is a technique which is still under observation.
Yes.
It is not recommended by the experts, and we are started to use it. But you must be just aware that it's a new technique. So therefore, I asked.
Yes.
It is still not 100% approved because they are saying that the long-term results will show whether we are actually justified in going beyond the PUJ. And secondly, we don't know about the failures. What if the scope gets stuck in that position? Then you have to be very careful.
Yes.
And in this case, it could be quite challenging because there will be edema and it will be difficult to push the sheath beyond. So definitely PCNL is a better choice in this case.
No, I was talking about the left side.
हाँ नहीं sir, right side I'm saying.
नहीं राइट
For
तो
right side,
PCNL कर दिया, अभी
yeah,
लेफ्ट
yeah,
साइड की ट्रीटमेंट की बात करते हैं.
yeah. Any other way you want to make it very fine dust? That also is
Dusting mode of the cell.
Dusting mode of
Laser, sir.
So how do you do that?
So there is a setting on that.
So what are the settings you will choose?
7.5.
See, dusting mode also doesn't dust it very well. According to me, the fragmentation mode is the best mode where you very fine dust. When it comes, you 6 4.
Hiren, your voice is cracking.
Should
See, nowadays, compared to holmium, thulium is much faster and also it makes much dusting is very good in thulium. What is your experience, Pankaj bhai?
So I do not have much personal experience with thulium fiber laser, but yes, for dusting purposes, TFL is much superior to holmium laser. But with the newer holmium laser technologies like Moses laser, and if you use a very low joules at high frequency, you will still be able to dust fairly well. There are no studies which have said that one laser is superior to other in, say, long-term stone-free rate. Stone-free rate overall is nearly similar for both the lasers. The time taken may be a bit different. So yes, TFL is one of the newer lasers where dusting, especially in kidney, is much superior. So when you have to say what are the precautions you will take to make the stone completely stone-free, one, you should say that if possible, I will reposition the stone from the lower calyx to upper calyx.
Yes.
Always the stone-free rate is much better in upper calyx as compared to lower calyx. Then you would take time and gradually dust the stone. So when you are dusting, the lowest possible energy and the highest possible frequency, and gradually keep on painting the stone with your laser energy. So you are creating fine dust as you are breaking. At the end, if there are some fragments, you should always pick those fragments up and place a stent. The newer innovations here will be to, as you have rightly said, fans or any of the suction access sheets. But The problem with suction access sheaths are two. One, that these negotiable access sheaths, to position them in a particular calyx, the amount of radiation needed is much higher. Okay. We do not know as Hiren also said, we do not know the long-term consequence of a large sheath going across the PUJ, whether there will be a higher risk of strictures at the PUJ. Third, the amount of suction to apply to these sheaths is very difficult to control. If you apply low suction, then the dust clearance doesn't happen. If you apply a higher suction, then the system tends to collapse. And in a collapsed system, the fragments will not come out because the collapsed system itself will block the fragments from coming out. So these fan systems are good. These are under, say, experiments at this time. They have a big potential. As we learn, probably we'll be able to learn to use them better. Yes, the aim should be to clear as much stone as possible on table, because if we leave behind fragments, there are a lot of studies which have said that just dusting or fragmentation, and if you redo a CT scan at maybe 4 weeks, the chance of having residual fragments is very high as around 20 to 25%. So if we can clear the fragments, it is always better. Probably the long-term recurrence rate will be lower.
I think this is quite clear.
Post-operatively, you can do things like adequate
personally
hydration. You
don't
can
use
add alpha
the
blockers.
dusting mode.
Sorry, Hiren, please go ahead.
Yeah, sir, I personally don't think mode so much. I use mainly the fragmentation as well as the popcorning. But the popcorning I use only for a few seconds or maybe half a minute at the end. And with the fragmentation mode, like what we have seen in all the workshops also, it does very well.
Absolutely.
So,
So your policies
there
should
is,
be either
we
fragment
have
and
to,
pick up or dust
correct.
and leave behind. Yes.
Yes, sir. And it is very essential now to understand that we have to use the energy very carefully in the kidney. The recommendations have been completely changing. Even Professor Traxler has changed his own statement. First, it was we were using higher frequency, then it came to 25 watts. Now it's come to 15 watts. Now it is even less than that. They're saying not
10.
more than 6 to 10.
Yes.
So,
Yes.
and recently he said that we are baking the kidney. So you have to be very careful because as of now, we still don't have any heat sensors. Maybe that is the future, that the exact study of the heat inside the kidney will give us more idea.
So continuing with this point, Aditya, no, sorry, yeah. What are your ways of seeing that temperatures don't go up inside the kidney? What all precautions will you take?
For that, we have to give there is a either continuous infusion of saline with the constant rate, or either manual one assistant person should be give a infusion of normal salines.
So I would again caution you.
Yes, sir.
I These pumps are of no good.
Yes.
It's
Rather bad.
very bad because they are the reason for the infectious complications.
Yes, sir.
So I
So
always
if
attach
you,
a pathfinder, but the purpose of that pathfinder is that when you have a device in your channel,
Yes.
like a laser fiber or a basket,
Yes.
at that time the irrigation with the help of a pump or a pathfinder will help you.
Yes. So in
Otherwise, it should be by gravity only. Because the channel is only 3.6 French, when you have a device inside, either a laser fiber or a basket,
yes.
and that also you have to be very careful, use a 1.7 French basket. The minute that basket is 2.2 French, your flow is completely gone.
Yes.
So therefore, only when you're picking up a stone with the basket, then maybe your assistant should help you. So that is not the way. The first thing is that you should have adequate drainage of the kidney.
Yes.
So you have to look at the access sheet whether the return is
So
coming
yes.
well or not.
Yes.
There have been some studies where they have tried to use cold saline, but there is no evidence that it helps to reduce the
Yes.
heat. So you just use normal body temperature and no forced irrigation. That results
and
in,
last thing will be a stop and start technique for laser.
Correct, correct.
So do not continuously keep on firing.
Yes.
What they say, 5 seconds off, 5 seconds on. So you laze, give time for the dust to settle down. Your temperatures would also go down and again start lazing. So continuously lazing at high frequency would increase the temperatures a lot. And remember, for temperatures, it is frequency which is important and not energy. By logic, we may think that it is the energy which is important, but the studies have shown that the temperature rise depends more on the frequency.
Yes.
So earlier they were recommending high frequencies, just adding to Sir's point. But now, if you see, most of the machines have got pulse width settings.
Yes.
So they have been actually adjusted for you. So they give you dusting mode or fragmentation mode. So there the frequency and energy has been adjusted. Earlier, when we started only using holmium laser, we were using low frequency and very low energy and very high frequency. Now the concept of frequency is also going. It is now pulse width. So pulse width is actually what is helping you do the fragmentation as well as dusting. So the newer machines have got pulse width settings adjusted from the factory. Therefore, they have those
increase
preset
the pulse
modes.
width, there will be more dusting. When you reduce the pulse width, there will be more fragmentation. Can somebody tell about Moses technology?
Come on, you know it. It's something to do with the bubble. What happens with the bubble? How does the laser work actually? What is
Sir, it's
cavitation bubble?
on the surface of stone, sir, the laser form cavitation bubble or plasma. And
So what
will
is
create
Moses technology? What exactly happens?
What is Moses technology doing to that bubble? What is vapor tunnel? You guys have to read about lasers, huh?
Yes, sir.
You should read, then we discuss in next class.
Yes. Yes.
Because without you reading, there is no point
Yes.
discussing.
Yes.
So read about vapor tunnel, Moses technology,
Yes.
all these things.
Yes.
Okay, I think we had a good discussion.
Thanks.
Yeah. Pankaj, you wanted to say something to.
Sir, I was thinking पहले हम लोग थोड़ा discuss कर ले हम करना क्या चाहते हैं.
Okay.
Means I had few things in mind, but first let's us discuss and then we will put it to the students.
Okay. No problem.
Yes, sir.
But at least on the group, we will write down that one of the students must, after this topic, why can't we tell one of these students to read a particular thing and talk next time from this
So
today's
yes, this
topic?
was there in my mind, sir, that maybe we give just 15 minutes to the student, not more than 10 slides and 15 minutes, where they cover some theoretical aspect of the topic that we are discussing. Because with practical, they also need to be ready for the theory part. So that way, everybody would know these newer things and we can discuss that. So strictly 10 slides, 10-minute presentation and maybe 10-minute discussion.
Those 10 slides, you should just put points. Don't fill up the slides. Just put one point and then talk about it.
Exactly. So my thought was that it will help you prepare your theoretical topics. It will help you also make presentations and present.
And it will be like a small subject seminar. So we will also learn from it.
Precisely.
So can one of them prepare about laser next time? 10 minutes.
Yeah, it should be a good idea, sir. Good idea to prepare about all the lasers and the newer technologies.
So Anand, you will do it?
Next week, sir, on Tuesday we have transplant service, 2 transplant.
Paras can do it, sir.
Yes, sir, I will do it, sir. I will present, sir.
Okay, Ganesh will do it. Good.
Yes.
We appreciate it.
Yes. Sir.
Very good. Okay?
Yes.
Yes.
Okay. And
Thank you, sir.
remaining thing we will discuss out. Okay?
Sure,
Yes.
sir.
Yes.
Sure.
Okay. 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 Good night, everybody.
Thank
Good
you.
night, Pankaj sir. Good night, Gaurang sir.
Thank
Good
you,
night, all
Pankaj. You
students.
joined, but it was a very fruitful discussion you had. Thank you very much.
Thank you, sir. Thank you, sir.
Thank
Bye.
you, sir.
Good night,
Thank
sir.
you, sir.
Good night.